And Dr. Carmona, we're also putting this on Facebook Live.
Oh, good. We're going to be famous, Elena.
Yes.
or infamous.
This will be beautiful. I hope you're having a nice day, weather out there in
Us. Well, it'll be another cool 105-degree day out here. I'm in Arizona today. I'll be in California tomorrow. I just moving around a lot. But
Yeah.
I don't miss the humidity back there in the summer.
Oh, no, I know. It hasn't been bad though, honestly. With
Really?
the change, we're enjoying a mild summer.
Oh, nice.
So.
All right, Dr. Rios, people are continuing to flow in, but I think at this time we have a good amount on the webinar and we can get started whenever you guys are
Okay.
ready.
Thank you. Thank you, Vincent. So I'll just go ahead and start. So thank you everyone for joining us today. This is the National Hispanic Medical Association's COVID-19 virtual briefing series, session number 17. We started in April or May of 2020 with the COVID pandemic beginning, and we have consistently heard from experts about the lessons learned from COVID-19's pandemic and how we can improve things as we move forward, not only with COVID-19, but with monkeypox and with other epidemics and pandemics that we will be seeing in the future. Today, I have a great privilege and honor to have with us Dr. Richard Carmona, Surgeon General Richard Carmona, who was the 17th Surgeon General of the United States. And we had the pleasure of actually having Surgeon General Carmona at his first public speech was at the National Hispanic Medical Association Summit with the U.S. Department of Health and Human Services and the Congressional Hispanic Caucus back in 2002, in San Antonio with Congressman Rodriguez, who was the chairman that year. So Surgeon General Carmona, you've been a good friend, a partner, and we look forward to hearing your wisdom today. We're going to have a presentation by Surgeon General Carmona, followed by questions and answers. And I would like to ask all participants to please mute your microphones and then put the questions for Surgeon General Carmona in the Q&A box to keep our chat box open for any information that we need from our staff. And I want to thank our staff again, Vincent Garrity, our NHMA program manager, for doing a great job in coordinating this webinar. We will also have a short post-webinar survey be emailed out after the event, and there will be a Q&R code at the end for a raffle. The recording of this webinar, as is all of our COVID-19 webinars, are on our website, nhmamd.org, and it will be up next week. We also have it connected to our YouTube channel. Next slide. So the title of the speech today is COVID-19, the Great Unifier, Divider, and Accelerator. And again, Surgeon General Carmona is a distinguished laureate professor at the University of Arizona and the 17th Surgeon General of the United States. Richard, you want to continue?
Yes, Elena, thanks so much. And first and foremost, want to thank you for your friendship, your leadership, and I've known you and had the privilege to work with you now for a couple of decades, as you said. And you know, you're the driver, I guess the godmother of the National Hispanic Medical Association. You got us together in the beginning, and you've kept us together through all these years, and have grown the organization to be a formidable organization that can affect policy change. And so I think we all owe you a debt of gratitude for that. Today, I have been asked to provide a brief overview of the national COVID response, which I'm happy to do. But I want to give you the response from several perspectives. It's not just me as a Surgeon General, but as I look through the lens of all of my life experiences, it gives me a much broader context of how I dealt with this. And I hope you will see that in my remarks, they're not just about science, it's about policy, it's about sociology, it's a whole host of issues. And all of those issues really have been part of who I am and the journey I've taken throughout my life that has sensitized me to many of the issues we'll speak to today, things that Elena and I are very passionate about, the issue of health disparities and some of the social determinants of health and how they were affected by COVID. So first and foremost, I look at this as the oldest child of poor Hispanic immigrant parents. Me as a high school dropout and who experienced homelessness, health disparities, and understand what that's like. Those are not theoretical constructs for me. They are actually experiences that I and my family have had in assimilating into this big culture in the United States, where my parents' first language was Spanish, and I learned English as the first generation learning English. And I look also as a first responder for over half a century. And as a soldier, as a paramedic, as a police officer, as a registered nurse, as a physician, as a hospital and health system CEO, as an emergency and public health director, as a professor, as a trauma surgeon and critical care doc, and then Surgeon General of the United States. In each of those experiences over half a century, I have been involved directly and indirectly in emergency preparedness, from boots on the ground and saving lives, right up to, at the White House and making policy at HHS and with the Congress as it relates to the health, safety, and security of the United States. And then, last but not least, just as a father and a grandfather who witnessed the family and community impact of COVID firsthand with my children and my grandchildren and how to protect them. So all of those experiences over these many years have sensitized me a great deal, but have also given me the privilege to serve because of the experiences that I've had. So my life experiences have prepared me and allow me to share with you this presentation on what we're calling COVID, the Great Uniter, Divider, and Accelerator. And it's a title I came up with quite a bit of time ago, early on in this challenge that we've been faced with the last 2.5 years, because I saw so much of the burden that was thrust on people and the negative discussions. And I started thinking, well, COVID has clearly created a burden for us, but in a lot of ways it's united us and it's divided us. So just briefly, I will touch on that. And as I look at COVID as a uniter, it really has brought together people in the following way. And I'll give you an example. In Arizona, at the University of Arizona system, as well as at the state level where I was the incident commander, we have facilities managers now knowing the doctors firsthand, anthropologists, journalist students who now are in fact associating with scientists and doctors. And almost everybody has become an amateur epidemiologist because we're learning from each other in order to survive in this very complex environment that is thrust on us with a pandemic that really might be characterized as a once-in-a-lifetime event. Yet over the last 15 or 20 years at the university, on an annual basis, we do scenario training with all of our multidisciplinary students, and often it's pandemics, flu, accidents, plane crashes, but how do we come together as a community and surge? And so the challenge here of uniting us around a common purpose was one that I saw. Now, that's not to say that we didn't have problems, but a lot of people from disparate backgrounds came together to bring their core competencies to the table to figure out how do we deal with the first pandemic in over a century. And yet, we also saw the divisions, some of them largely political. We saw disinformation and misinformation. We saw people who were not selfless, but were self-serving, utilizing this particular catastrophe for their own benefit, to divide us further. We saw people who were uneducated and scared, and although not purposeful, went astray with their thinking because they didn't know what to believe. And a lot of it was because people in leadership positions were essentially confusing the public because there was not a consistent message, if you will, a Roosevelt-like fireside chat, where a credible person every day gave a briefing to the American public as to what was going on, what your government is doing for you at a national, state and local level, yet mixed messages, where politicians were canceling out scientists and scientists were struggling to get the good information out. And then scientists who were some not prepared, because one of the things we don't do real well, we don't memorialize or preserve these lessons of the past. So a lot of the things I'll talk to you today about were national preparedness policies that were generated a couple of decades ago. But a lot of the people who were at the table when I was there have since retired. And yes, if you do a library search and you look at articles and publications, certainly that information is there. But we really haven't done a very good job of memorializing and translating into each generation the lessons of the past, because history is the prologue to our future. And often we forget that history. We make the same mistakes as we move forward because we haven't memorialized, captured, integrated those essential elements of history to preserve them and use them as we move forward to decrease morbidity and mortality. So we've seen how COVID has united us. We've seen how it has divided us. And I will say the politics have been terrible. The misinformation, the disinformation, the conspiracy theories, and the public is looking for somebody that they could trust. What generally happens is they revert to places that they feel comfortable. Maybe it's a political party, maybe it's friends, maybe it's social organizations. But think about the multitude of interpretations that they're trying to filter, and they don't have the information or knowledge or scientific capability that all of you have to decide what is scientifically meritorious to be able to act on and to do something that benefits the health, safety, and security of our families, our community, our state, our nation, and the world. So again, going back to Uniter, Divider, and Accelerator, the accelerating part is kind of interesting because early on in communications with my colleagues at NIH, CDC, global resources that we all have after being Surgeon General and staying connected, I saw the greatest crowdsourcing of scientific information in history. I saw scientists in the private and public sector sharing information, some of it proprietary, some of it in laboratories that they could possibly make a business out of. But yet they recognized the greater importance was to share this information, to accelerate to a vaccine, to start immunizing people to prevent the spread of this very terrible disease that will continue to evolve as long as lots of people aren't vaccinated. As long as they can find a host, an unvaccinated person, for that virus to replicate. And as all of you know, over time, that virus keeps mutating because it wants to survive in our world as much as we don't want it to survive. And those mutations, of course, render it different characteristics, could be more transmissible, it could be more lethal. And as you know, we've gone through many variants since this started 2.5 years ago. And so the beauty of the acceleration was I saw email trails from all over the world between my NIH colleagues, CDC, universities in our country, sharing information so that we can accelerate science to be able to get that vaccine out. And that mRNA vaccine was confused. Some people thought they were being experimented on. How can they bring us a vaccine right now and they don't even know how it works? Well, that's not true because most of you know that mRNA vaccines have been around a couple of decades and the science behind it have been around that long. All we did was apply accumulated science over a couple of decades into this new vaccine and then got it out with an emergency use authorization, okay, because we didn't have the luxury of waiting a year or two in large cohorts of people to test it, but it was deemed to be safe. And that's what we found. It was safe. And it had a tremendous effect on society in providing us some protection. But again, misinformation, disinformation, people would say, well, we get the disease anyway. It doesn't work. Not so. The vaccine's primary importance is to keep you out of the hospital, to mitigate you from becoming a very sick person. So to hold on to that disease at a mild level, okay, and prevent death and disability. And yes, it may prevent some people from getting the disease, but the most important thing is if we can prevent you from being hospitalized on a ventilator and dying, that vaccine is very successful. But yet the public, confused by all of the mixed messages, especially people who were anti-vaccinators and saying that they were being experimented on, again, more confusion, more delay, more divisiveness politically, right, from the very low levels right up to the White House. And unfortunately, all of those contributed to more morbidity and mortality, which would have been preventable. So again, in keeping with the theme, the great uniter, divider, and accelerator, maybe the first thing I need to talk about, again, just very briefly, because I want to leave plenty of time to have the discussion with Elena, but also to field your questions in the last 15 or 20 minutes. Number one is the concept of this concept. We have the National Response Framework. There's a document out there that all of you can see, and especially those of you who are not involved in national or global emergency management, your nation has a document by which we surge. We come together with multiple disciplines to meet a threat caused by any and all hazards. The term all hazards is anything that can affect the health, safety, or security of the nation or the world. The reason we chose that term a couple of decades ago was on the days we met to put this plan together, we recognized that we knew what the threats were today, but how do we handle threats in the future that we don't know? Back then, we didn't have active shooters. We did not have a lot of the challenges that we are seeing today, because all hazards means anything and everything. It could be a pandemic, but it could also be a bio event. It could be an accidental spill. It could be a terrorist event. So we had to figure out a way to put this all into a single area that denoted any and all things we know today and any all things come in the future. Why? Because the response is going to be by the same people, the same police, paramedics, soldiers, National Guard, all of those come together and in a given community. And many of you know in your own community, when you have in a small community and you have a major accident that basically causes you to get assistance from other communities in what we call mutual aid, it's because the resources in that community have been exhausted by whatever the emergency is. Maybe it's a plane crash. Maybe it is a chemical spill. So we have compacts where we have relationships with other surrounding communities, other surrounding states. And when we do that, it's called surge capacity. We all move up and expand the response capabilities because of this. And that's really how our nation works for any and all hazards. The National Response Framework memorializes that concept. You can find it at hhs.gov. You can find it at FEMA.gov. You can find it at DHS.gov. And it's a pretty sizable book, but it breaks down how our nation approaches all hazards preparedness to include pandemics. Again, the understanding that this is all hazards, pandemic is one of them. It defines our surge capability, meaning how do small communities come together to meet a bigger challenge? How do even larger communities at a state level then come together to deal with the challenge? And what happens when the state resources are exceeded? Well, the state then has the ability to contact Washington. There's something called a Stafford Act that releases federal resources after the state resources have been exhausted. And now it becomes a national emergency. Federal dollars, federal resources can be directed at it. And that's what happened with this pandemic. So first and foremost, if you're not in this field, it's something you should take a look at to understand how the system works. Next question that we should be talking about is that what was the status of our public health preparedness in December of 2019? A little history there. Back when I was Surgeon General, we started realizing that it was very important for us to have adequate global surveillance of any and all threats that were out there that could ultimately come to us. Many of you have heard about SARS and avian flu, a whole host of the things. But it's important that we know, even malaria, infectious diseases, other things, because any of those challenges that are hurting many of the other countries in the world could ultimately end up here in just one plane ride where somebody shows up with a disease and begins to spread it. So because of that, we had a special team on the National Security Council, whose job was specifically to have scientific surveillance. That included also weather, travel patterns, geospatial studies. You know, how do viruses and bacteria move between persons, between animal and people, so-called One Health, and how does it get to the United States? We also have many relationships with our allies around the world so that we can assist them but it also helps us because we have early warning when we see something happening in another country. And it's not only our allies, often it's with our adversaries as well. Our CDC had relationships with China, which helped us to get a leg up on some of this. But of course, because of the cultural differences and political differences, it's not always as quickly as we would like. So that surveillance on the National Security Council was important. Also at CDC, at the time we have our push packages as our strategic national stockpile, which are a dozen places around the country where beds, medicines, ventilators, anything and everything you may need to deal with an emergency if a given community or region doesn't have the resources. They're depleted because of a big event that happens at one time or a big event that continues and resources continue to be depleted, supply chains are compromised. The nation has a lot of these places around the country secretly because you don't want your adversaries to know where they are. That used to be part of CDC. It's moved now to the Assistant Secretary of Preparedness and Response, but it's the same response capability. So those two things have to be both the Strategic National Stockpile and the National Security Council's team have to be very robust. There's a team that would keep the stockpile ready at all times, make sure that the medications hadn't expired, make sure that the ventilators and generators are working. And the people at the National Security Council, 24/7, they're watching the rest of the world to ensure there's nothing that's going to come and hurt our nation. Unfortunately, in the last administration, they disbanded that team. They didn't feel it was necessary. And the Strategic National Stockpile was not cared for as it should have been because there was a period of calm. We hadn't had a big challenge since Katrina. And so, and the tsunamis in Indonesia, which we responded to. So for whatever the reason, political or otherwise, those particular entities were not there to care for us. And we saw what happened when this first rolled out because we needed masks, but there weren't enough masks. We needed vaccines. We needed additional equipment. And there were questions, where is this stuff? It's not ready. So our preparedness was less than optimal and from surveillance, and our preparedness as it relates to all of the equipment we needed quickly, including masks, were not ready. And of course, it's embarrassing that the greatest nation in the world has to start shopping around to find masks any place in the world. And people are making homemade masks out of t-shirts and underwear, for instance, when this first started. So those are all real things that happen and should never happen again, but we have to make sure we're always prepared. When people make impractical decisions to defund or not keep these important organizational infrastructure in place, this is what happens. The analogy I often use is we don't see many fires in the United States today, but we still fund fire departments. We ensure that those firemen are trained well. They're almost all EMTs and some of them paramedics, because not only do they fight fires, there are infrastructure for response. We don't close fire departments because there's not that many fires. And so we as a nation have to be willing to invest in infrastructure that's always there when any and all hazards threaten us, because we can't always predict when those will happen. So our status was suboptimal. And when we think of the arc of all hazards preparedness, when we have the situational awareness and we see something developing around the world, the first thing we want to do is prevent it from happening. Let's get over to that country, help them send mutual aid, drugs, support, vaccines, whatever, but let's contain it there before it becomes a global issue. Okay, we were not able to do that this time. And so prevention is number one. The second part of that arc is response. So when we miss the prevention opportunity, we respond, and the response you've seen play out the last 2.5 years. Just about everybody became part of response. And so we are still in a response mode in a lot of ways, although it is attenuated now. And when you move from response, then you move to mitigation. And mitigation is everything I can to stop the spread. And what do we do for that? Well, we stop travel. We shut down cruise ships, planes shut down, people stay home. We have social distancing. We're wearing masks. We're vaccinating. So all of those are a way to mitigate as quickly as possible. And after mitigation is recovery. And we're starting to try and move into recovery now. But the challenge, of course, is the virus is still out there trying to survive. we're doing better because more people are vaccinated, but still a third of the country is not fully vaccinated. So they're more vulnerable. And not only are they vulnerable themselves, but they are in effect petri dishes for this virus that can get in their body and continue to replicate and maybe mutate, which drags this out even longer. So when we look at where we are today, we've gone through that whole sequence of prevention to response to mitigation and recovery. And as we look at where we are today, we are trying to recover. We're still mitigating. We still have many problems. We have people that don't believe in vaccines. And as a Surgeon General, I will tell you, vaccines are probably the most significant advancement in the history of science, in the history of mankind. Because when you look at your history going back hundreds of years ago, where whole populations and countries were wiped out from plague and things like that, vaccines prevent that. And why do we vaccinate our children? Measles, mumps, rubella, tetanus, whooping cough, because we don't want them to have those diseases. So vaccines are very safe, and vaccines are very available. Polio is another one, the more recent example, where it's almost eradicated polio in the world because most people get vaccinated. Where we see a recurrence of diseases like whooping cough, measles, rubella, tetanus at times, it's because people aren't being vaccinated. And a lot of that was because of misinformation and disinformation. And so my message to everybody, and especially here with the National Hispanic Medical Association, where sometimes language and culture becomes a barrier, we need to do the best we can to reach out to our fellow citizens, especially in the Hispanic community, to understand the importance of everyone getting vaccinated, because it not only protects you, it protects your community from these viruses getting in your body and being able to replicate. So very important. The plague of politics and misinformation and disinformation really challenged us a great deal and continues to challenge us today as we try and move forward. And, you know, elected officials making comments that, well, this is all going to go away in the warm weather, you know, and basically undermining the validity of vaccines or therapies that science has promulgated. All of those confuse people. They're not sure what to do. And so a lot of them revert to their social groups, their political groups, where they're driven to take action that is not in the best interest of themselves or the community. The other challenge, of course, is as we look at our political cycles, they rotate every 2 and 4 and 6 years. So it's hard to have consistency in messaging because of the political winds chasing as well. And I have been fond of saying that the plague of politics can be arguably seen as maybe as virulent as the virus itself because of how it divided us and prevented us from doing what was appropriate in a very, in a quicker manner. Let me put it that way. So what went well? What went well in our response was that we did have an infrastructure that surged. Local communities, fire departments, volunteer fire departments, municipal fire departments, police departments, universities came together. We crowdsourced information from around the world and around our universities. We started testing, doing wastewater testing. We developed different types of vaccines and testing. We had saline gargles. We had PCR tests. We had antibody tests. Think about how fast that came along. So it's something we can be proud of, that we did come together and crowdsourced information for the betterment of society. So, you know, that went well. As we look at the mobilization of our resources, especially the supply chain, our military stepped up and helped us a great deal because there is no place in the country that can do this alone with the extraordinary needs of a nation and have a supply chain that's consistently delivering food and water and medications and ventilators and vaccines. And so that was quite remarkable as well, the issue of supply chain in a pandemic, which is now, again, we're going to be going into third year come December. How do we need to improve? And the most important thing now in all of your communities where you are functioning at a local, state, or national level, we need to look at these after-action reports. And these after-action reports need to be nonpartisan. We need to be able to tell the story of what happened, do a forensic dissection, and, you know, sometimes politicians don't like to hear it, but bring the inconvenient truth forward. to both parties. And my remarks are nonpartisan. Nobody wants to get bad information when they're in office because they're trying to protect their office. I understand that. But right now we have to put that behind us and we have to do what is best for the public. And what is best for the public in these after action reports is to tell the truth. What went well, what went wrong, what infrastructure changes do we need so that in the next all hazards event, whether it's a pandemic or any other threat to the health, safety, and security of the nation, that we are prepared and we will meet that challenge in a timely fashion. Last and not least, the future of all hazards threats. When we look at some things that you don't think about, we look at the, for instance, the climate, we look at water shortages, we look at some of the weather changes that have been significant recently. All of those contribute to all hazards threats. Hurricanes, tsunamis, earthquakes, all of those are climate related. The fact that in the West, there are more and more water shortages, making it difficult to carry on a lot of preparedness activities or just life in general. All of those have to be factored into our planning for the future within our after action reports and really generating a new national response framework that includes these experiences. And last but not least, making sure that this all is memorialized and it is embedded in all of our teachings and all of our schools, from grammar schools right up to colleges and graduate schools, for our professionals who are there, so that everybody has basic knowledge of how the system works when and if we are plagued again with a pandemic or any all hazard threats that affects the health, safety, and security of any community, any state, our nation, or the world. So thanks for the opportunity, and Elena, happy to discuss with you further.
Okay, Surgeon General Carmona, you gave us a lot of information, very comprehensive. I love the title, Unifier, Divider, and Accelerator. And what I'll do is tailor a few questions I have while I wait for the audience, and I want to remind the audience to please give us your questions. This is interactive with the audience, but I'm going to just ask you a few questions based on those three topics. And let me just say that for the National Hispanic Medical Association, we're very interested in focusing in on our communities, the Latino communities across the country and in Puerto Rico and the Caribbean and of course Latin America. As you mentioned, CDC and the surveillance of global opportunity to transmit information from all of our communities and to learn from each other. Can you give us an example of how, let's say from Puerto Rico's perspective to the US-Mexico border perspective to a large city like Los Angeles or, you know, the Phoenix area, the Houston area, some of the lessons learned regionally for from Latino communities' perspective to offer to CDC and to the future of pandemic knowledge?
Well, thanks. That's a great question, Elena. And first and foremost, I think the paradox here is, and we see this every day, not just in pandemics, but the great strength of the nation in its last 250 years when it started is its diversity. You know, the immigrants who are willing to come here and work hard, take the jobs that nobody else wants, and build a family, and those kids go to college and they become doctors and lawyers and teachers, or they become carpenters, or they become electricians, but they contribute to society. Yet, the paradox here is the great strength of the nation is diversity, and yet it continues to divide us every day. And it divided us along the lines within COVID. And, you know, we saw, I'll do the negative and then get more to the positive, because it's something that hurt me a great deal. We saw right away people lashing out on Asian Americans because, and, you know, when from the top of our government, it's called China flu, okay? I mean, and all of a sudden, disparaging remarks and people being brutalized, and they have nothing to do with it. They're good citizens, just like all of our citizens. Number one, further division. And then when we look at the Mexico border, for instance, and at the Mexico border, you know, immigration has been a problem. The federal government has to do a better job there. But, you know, we are the bastion of last resort for those people who are trying to leave countries where they are brutalized, where they're being tortured, where there's drug dealers. We need a system to figure out how to do that, and it's not working well. But when COVID hit, of course, The brown people were being targeted. We can't trust them. They're bringing disease. They're killing our people. Again, divisive remarks that are hurting us rather than uniting us. In Puerto Rico, plagued already with hurricanes, half the island had already vacated. The pharmaceutical industry left. The tourist industry was decimated, and yet people without water. Okay. And what did we do? We had an argument whether or not they were really citizens or as a Commonwealth, should we help them? That was absurd. This is about humanity. It's not about politics. We help those who need help, period. And it should not be based on the color of your skin or your ethnicity. It's about fellow human beings who need assistance, and where we can provide it, that's where we should provide it. So all of those things became a problem. The other challenge, of course, is, Elena, as you know, whether you're in Mexico or South or Central America or Puerto Rico or the Dominican Republic, there are language and cultural barriers. A lot of the folks coming in, they don't even know what a vaccine is. They don't know what a virus is. They're scared. They see their people dying. It's up to us to educate them. But we need a clear narrative, an honest message based on the best science, not on the best politics, which again, confuses people. This idea that all Hispanics vote this way or that way, or they're liberal or conservative. No, we're just like everybody else. Some of us feel more conservative. Some of us feel more liberal. But what we have in common, we are human beings, and we deserve to be treated with dignity. And so it is up to us to craft those messages that inspire people to do the correct thing, not only to help themselves, but to help their communities by getting vaccinated, by washing your hands, by social distancing, by wearing a mask. Those are the things that have to happen. But in the communities of color, who not always, but often have the barrier of not understanding the complexity of the issue, it's up to people like NHMA to translate not only language, but culture and understanding, so that they can begin to make good decisions as well.
Oh, very good. Thank you. Let me take a question from the audience about the concept of dividing and misinformation from Kimberly, who says a common comment from people that she knows: when resisting the vaccine, they claim that the vaccine actually killed someone close. And especially in our families and our communities, we know the Latinos and the African Americans and poor general took the brunt of the morbidity caused by and mortality caused by the COVID-19. But what are ways to educate? What are the messages from your perspective as Surgeon General? To
thank you,
mentioned
Elena.
some already, but
well,
I think it
that's
would be
Kimberly.
important.
Thank you for the insightful question. First and foremost, we have to understand what is really going on. There's a term that came to be during this time. It's called vaccine hesitancy. We'll use that as an example. People don't want to do it. Why do they don't trust? First and foremost, well, why don't they trust? So let's look at the African American community. Okay, let's look back at the Tuskegee experiments. Now, those were a long time ago, but those stories are still within the culture, where grandparents still remember Black men not being treated to find out how a disease would end. Okay, so right there, you start to build a mistrust in government. Can I trust what they're saying? The Hispanic community. And so when you look at the different groups where they have been vilified, where they have been told something and not really truthfully by government, there's reason why their suspect is what they're telling me is true. So that's part of it. Another part of vaccine hesitancy is they just don't understand. We take for granted that our children get vaccinated. If you're coming from a little pueblo in Mexico, okay, or you're someplace in rural Puerto Rico or someplace, you may not even know that. You may not have any understanding. So the complexity that tends to be reduced to one term, vaccine hesitancy, is confusing because it doesn't denote the extraordinary complexity in the population that we're trying to reach. So for us, we have to reach the population and find out, why is it that you're resisting? What is it you don't trust? Why would you not get a vaccine? And try then to educate so that they will be inspired to make the appropriate decisions. We have the credibility as health professionals. Sometimes governments fail, sometimes elected officials fail. But make no doubt, vaccines and the basic public health mitigation strategies are what will prevent transmissibility and help us to get out from under this cloud of COVID. It's up to us to be the articulators, to be the inspirational messages, to be the people of trust to those who see us as them, that we have brown skin, that we understand the plight, that we can relate to them. Those are all important as we did. I had to deal with this personally, so this is not just theoretical. In my own family, I have a niece who is a firefighter paramedic, and she didn't trust the government. And she's a paramedic rescuing people every day in a fire department, and she didn't trust. Okay, and here along the border in Arizona and California, where I work, same thing. There was a trust issue, and then there's a language issue, and then there's a cultural issue. But it's not easy, but if you understand the proximal cause, you can make progress.
So one of the, I think, rising, I'm going to say phrases that came out of this, that is part of understanding our culture, is the concept of essential worker.
Oh, I love it.
Before. And honestly, I think we were able to become a focus of attention. Not only the Latinos in the along the border, but also with the the cities, the urban areas, the rural areas, the chicken plants, the meat packing plants, the farm workers, and then in our urban areas, just everyday people that work in our supermarkets, or that have to do with our gas stations, all the places that were not closed by the government became known as places where essential workers worked. Nothing new to our families and our communities.
Right.
How do you see the importance of allowing the essential workers to become part of the healthcare system?
Right.
They're not insured. They don't have access to doctors or dentists. They are the poorest of the poor when it comes to health information. And it would be nice if for NHMA's sake and for other organizations who want to help the health of our communities, we have access to better policies to help the essential workers.
Elena, well said. And a little background, give a little color for this. Early on in this pandemic, probably, I think it was around March or April in 20, my colleagues and I wrote a piece, published a piece in what others were seeing at the same time, the disproportionate morbidity and mortality in people of color, which was what we call health disparities. It wasn't less access to healthcare, poorer, less education, not knowledgeable. Plus, they're being confused by all of the hyperpartisan political rhetoric. And so, interestingly enough, around that time, and being that I working mostly in the Southwest and spent a lot of time along the border, I started thinking about this issue of essential worker, because back when I was still Surgeon General and we were dealing with Katrina and tsunamis in Indonesia and other SARS and avian flu and all of these other things. And, when we would talk about scarce resources being demanded, the discussion always came up to be, okay, well, we have to make sure that we provide these resources, for instance, medicines, vaccines, to our essential workers first. And most of the time people thought, oh, that's paramedics, doctors, frontline people. And then it was like, well, but what about the pilot who flies the plane that brings you the supplies? Well, yeah, they should be included too. But what about the truck driver who's driving that stuff to the health clinic to get to the people? Well, yeah, you're right. But this time it was different, because in the pandemic going on that long, and across, of course, many people know that across the Southwest, most of your vegetables and fruits and food from ranches comes there. And who is more likely to be working in those positions? Poor Hispanic people. And then we had politicians say, well, this is in the past, not that when this happened, but when we would bring that up, it would be, well, they're taking jobs from Americans. No, actually, I don't know any Americans who will work in a field in the hot and 100-degree days for minimum wage and sleep in a little shack and go home every few days to bring the money back across the border so that they can make a better life for their family. And in fact, that was proven. Americans won't take those jobs. They are tough, tough jobs. But our people take them because they see it as a first step in a pathway to gaining independence, education, and appreciating the American dream. So we started writing about that as well. And I said, here's what we're forgetting about. And a couple of presentations, I said, we're missing maybe the most important essential workers. If those people along the border, our people, don't pick the vegetables, get the meat, do all those things, we don't eat. And if we don't eat, everything else doesn't make any sense. So right now, there's a greater understanding that essential workers are essentially those usually, in our case, Hispanics along the border, but also other denominations, and they tend to be poor people who don't have many other options that work those jobs. But make no mistake, they are absolutely essential, because if they don't do their job, America doesn't eat.
So let me talk about Accelerator. And we have some questions from the audience about the importance of considering the next pandemics that we are about to see, those public health hazards, as you mentioned, that are already in our borders, monkeypox, polio. I had a cousin with polio from the 1940s. And I remember my dad talking about how the whole family
Yes.
would go visit him in the iron lungs at the USC County General Hospital. And, you know, we thought that when I was a little kid, we got the little sugar cubes for the polio
Right.
vaccine, and we thought that polio was wiped out, you know, and just like smallpox, and now we're having monkeypox. So I want to just preface this with the Biden administration and Secretary Becerra developing the concept that we should raise the importance and the resources for preparedness by changing ASPR, what was it, the Assistant Secretary for
Prevention and response.
Prevention and Response, to an agency. It's going to be an agency like HRSA or FDA or NIH. And that agency is now an accelerator example. But what do you think should be the way to go now with monkeypox and polio in terms of foreseeing how we can better be prepared? And I'll just say there's a few questions here about how we have seen and learned from the COVID-19 about the infrastructure needed in the community, medical mobile units, more people on the ground in our healthcare system, like the health workers. So we've learned a lot of lessons, but what do you think we can start mobilizing around for monkeypox and polio, especially for our audience?
Well, there's a lot to unpack in that comment, Elena. So first and foremost, I'll start with the organizational structure. The fact that they're giving more importance to the Assistant Secretary of Prevention and Response, that's good. But the problem is that every administration, you know, when I came on as Surgeon General, all of that came under me. Then they kind of split it off and created a new agency. And so what we really need is, I think, more of a military model. I mean, the fact that every time they come in, they change and they move things around. And I'll be quite frank with you, sometimes people who get some of these jobs as political appointees, they're not the people you'd hire in a competitive job in the private sector, okay? Now, that's not always. We get some great people, but if you look at the military model, you get promoted up and you have more span of control, and ultimately you're responsible to an admiral or a general who's running the organization. And it's very predictable because it doesn't change unless there's needs in the community to change. In other words, taking ASPR out and making it a freestanding organization, it still has to report to somebody, okay? And if it's not going to be funded, and if it's going to be politicized, then really it doesn't make any difference at this point. We need a more rigorous organizational structure that is outside of politics, even though by our nation's standards, the elected officials still are the ones who dictate what happens. But execution occurs at that soldier, sailor, public health level based on policies that Congress approves. So I think we have to be careful of just assuming things will be better because we move one organization differently on the box. There has to be a commitment to allowing them to do the right thing. There has to be a commitment by Congress to not only, how can I put this delicately, that even though they may be in office, they have to be willing to get inconvenient truths at times. That people are dying, that bad things are happening on your watch. We're not blaming you, but we need to accept responsibility and fix it. And often that's a problem, that it's of accepting the inconvenient truth rather than trying to shade it. Both parties do it at times. So again, this is unbiased. But I think in the military, what I liked in my years there before Surgeon General, as you know, in Special Forces, it's like the politics are not important. You have to be aware of them. But ultimately, you're expected with your integrity to always tell the truth, however inconvenient it may be. to take the appropriate actions. So I reserve my final comment to see how this plays out, because a lot of it is going to be on how much support. I mean, CDC was carved out years ago, and they're alone down in Atlanta. But look how much politicization has occurred in the last year or two with CDC, who is a fantastic organization. So again, my warning is we have to be careful. The ultimate solution is not just moving parts of the organization in different directions, but actually empowering them to do their job and being willing to accept some inconvenient truths at times to do what's right for the American people. As far as smallpox, monkeypox, and so on, good news is monkeypox is not very transmissible. Mostly about 90% or more of the cases now are MSM, men having sex with men. You can still get it, with close contact otherwise, but all of the public health information is what's going to prevent this from spreading now. Making sure we get into the gay communities especially, and that we provide the right information to people so that the disease does not spread. It is very rarely, if ever, lethal, but it is a source of significant morbidity if you get the disease. Polio, you brought up. Polio has almost been eradicated in the world, except for the developing world. So we don't see cases anymore in the United States, except there's a few cases we've seen now in the United States and around the world. And so polio is a perfect example of the value of accelerated science, Sabin and Salk in the 50s, and whether it's a sugar cube or an injection, being vaccinated and essentially almost eradicating polio around the world, almost. But the message we should see now is, as polio is popping up again around the world, and it's not an epidemic or a pandemic, it's popping up, we should double down on making sure everybody gets vaccinated. And that was a problem with COVID. As we exhausted our vaccine supplies in a country of 330 million, and in the rest of the developed world of a couple of billion, what about a couple of billion people that don't have clean water or sanitation or food? They become petri dishes for the virus, and that virus will continue to replicate and spread. And when we brought that up, it became political. People would say, well, why? And I'm going to be quite blunt. When you have a leader that calls those countries shithole countries, okay? And why should we be helping them? Well, you can do it for two reasons. We have the resources, and it's a humanitarian issue. The second reason is, if you want to protect yourself from a disease that can spread back to us, get over there and vaccinate all of those folks, those billions who are living on less than a couple of dollars a day, where children die of malnutrition and dehydration, okay? We have to help stop the transmissibility of the disease. So you do it for humanitarian reasons, and you do it for self-protection. So that's my general comments on those. Happy to go deeper if you like.
No, that's fine. I think Surgeon General Carmona, your words of wisdom are appreciated by our audience. Getting some comments here about thanking you for your passion and also for your knowledge because of your long-lasting experience. Also, there's some important news that just came out this last month about CDC actually reorganizing, and the CDC Director, Dr. Walensky, commenting on a little bit of the future. She is going to create new executive council under a past HRSA administrator, Mary Wakefield.
I remember her.
Create an office of intergovernmental affairs to foster partnerships with all of the other agencies, and I would imagine the Department of Defense and DARPA and everything else that you were mentioning would be connected to CDC a little bit more, a stronger relationship. And there's going to be a higher level office on health equity. And what do you think that office should do? A new office of health equity at CDC.
Well,
In CDC, it's not just a United States agency. It actually is a global agency working with the World Health Organization and other organizations from other countries.
yeah. Well, CDC is the premier organization globally and has many relationships around the world. As many of you may remember, CDC is an outshoot of the Marine Hospital Office of Hygiene in Staten Island many years ago. And that became the CDC. And it was originally the Centers for Disease Control. If you remember, Elena, a couple of decades ago, we added on Centers for Disease Control and Prevention. okay, because prevention became a very big part of this as well. So I applaud Director Walensky for building a more robust team, strengthening the relationships. The relationships with DoD are already there. The DoD has labs all over the world that work hand in hand with CDC and other nations as well. So the relationships, DARPA, BARDA, all of those acronyms in feds, they're there, but to make them even better and sharing information, NIH included, those are important. But you have to remember, CDC is not a freestanding organization. If you look, they come under the leadership of the Secretary of HHS. The problem is, as they are geographically displaced, there's always a tension, you know, but ultimately it's the secretary that has responsible for all of those acronyms. CDC, NIH, HRSA, SAMHSA, they all come under HHS. Secretary Becerra or whatever the secretary is in charge. And that CDC director reports up to the secretary, sometimes through the deputy secretary or other reporting, but they're independent only based on the policy that is generated by Congress, that is executed by the secretary and overseen by the secretary and by the director of CDC. So I think it's great that they're going to work now to strengthen the ties to the community and work in a seamless, integrated fashion, which they have been, but maybe even better now, breaking down the silos, because as we've proven in COVID, crowdsourcing and immediate use of evolving scientific information is essential to preserve the health, safety, and security of the nation and the world when a pandemic comes up.
So let me switch to a couple questions about the future and Accelerator. One is about the importance of telehealth.
Yes.
This in telehealth, I mean, our national coordinator, you know, wanted to have interoperability for the last decade. I mean, this has been ongoing goal so that public health departments could collect more data from our doctors' offices and from our hospitals.
Yes.
Everybody on the same page with, even though they're different companies that deal with medical records, there was a concept that we should start using more computers for healthcare. The other thing that I wanted to mention is that we need better training of the doctors and nurses and
Yes.
other health professionals to connect to public health. Public health in our, you know, our ongoing tension, as you put it, between the federal government, the state government, and the local public health agencies is that they can only get data from the clinics or the hospitals that they actually license or that they work with.
Right.
So when you have private businesses called medical practices with doctors or surgery centers or radiology or laboratories, you know, these are all private businesses, and the private sector in the country doesn't work very well with the public sector. And when it comes to trying to develop more connections for telemedicine and to get to the patient, what do you think we can see in the future and how we should go about thinking about training now, you know, and not just training, but policies as well as for future training, I think, of our doctors and nurses to understand the importance of public health?
Well, I would start with, I could tell you at my own university, at the University of Arizona, the fastest growing department, if you will, or section is public health. Can't keep up with the demand for students that are coming in at all levels, undergraduate, graduate, PhDs, and so on. Many more doctors, MDs, and DOs are getting degrees in public health because they see the value of it. So I think the demand is there, that people are seeing that everything else is immaterial if you don't have public health. Okay, period. And so I think it's going in the right direction. What we have to figure out is a term we use in the military: how to enhance joint interoperability. You pointed that out, the public and private sector working together. They were forced to do it now, and they did very well in crowdsourcing information during this particular incident with COVID that is still evolving. So we need to enhance the joint interoperability. So things like CDC Director Walensky's doing with Mary Wakefield, to have that outreach and tighten up those relationships with public and private sector, especially government, like you said, DARPA and things like that. I think that also within the government, just looking, you spoke about like the electronic medical record and sharing information and so on. Well, the first czar was a guy named David Brailer, who's a dear friend of mine, who came in 20 years ago. He stayed a couple of years, but it was a very frustrating experience because to this day, we don't have a seamless medical record, for instance, between the VA and the Department of Defense. They're still working on it hundreds of millions of dollars later. And a lot of it is territorialism, it's politics, it's the rotating of the seats in administrations every 2 or 4 or 6 years, different elected officials coming in. And so you don't have that continuity of effort because the next group comes in and sees it differently. Okay. So somehow we have to figure out how to carry that joint interoperability through different administrations that come in when we all agree, especially Congress agrees through legislative power, that this is something we need to do. And we still haven't fully accomplished that yet. So the term I use is joint interoperability. In the civilian world, it's often called integration, that the systems can be compatible and work with each other. And of course, the last thing I'll mention is when something bad happens, every federal agency has to surge. So I give you an example. When we were doing Katrina, and even now with COVID, there were people that had said to me, why are you using the military for supplying? Why do they have to be involved? They have guns, and I said, they're not shooting people, but I said, nobody in the world has the capability of the military for supply chain. Okay. In Katrina, we exceeded all of the resources we had with fire and EMS and ambulances, that it was the military who moved 300,000 people from the Louisiana area to Texas, where we set up 3 stadiums that were health cities. But without the military's capability for supply chain, and that including moving people, helicopters, ambulances, medevacs, we can't do it. So the military becomes a very important part of our ability to surge on a national event and take care of whatever the challenges are, including supply chain and rescues and things like that. So once again, achieving joint interoperability during a surge capacity that is promulgated by all hazards threats, including pandemics, is important. So again, that after action report should include how do we strengthen those relationships? How do we test the relationships during peace and tranquility to make sure that we can communicate, that our radios work, that there's a seamless system, that the supply chain works, that the strategic national stockpile can go where we want it to. All of those become part of it, Elena, that has to be addressed in our after action report at a national, a state level. And last thing I'll mention on this was what became apparent to me as a Surgeon General during the last 2.5 years, that we acted more like a disunited states, not a United States. Each state was almost like a separate country. And when you watch policy emanating, it was often more driven by politics than it was by science. And that confused the people because people would say, well, I live in California, and why is Texas doing this? Why is Florida doing that? Why is New York doing this? There are reasons at times because of incidence and prevalence of disease and transmissibility, but a lot of it was because of political decisions that were made that flew in the face of science. So those are challenges, what I would call inconvenient truths that need to be put on the table so that we can do better at this next time when any and all hazards are threatening us.
Thanks for all of that. And again, Surgeon General Carmona is with us, answering lots of questions from his experience and very important for the future as we head into other pandemics. I have one question here from Ivy Welch about Puerto Rico as a model of success for vaccination rates. And I believe for COVID-19, learning about how a community work together to help their public health strategies. One of the things I wanted to let you know, Dr. Carmona, that we as an organization of doctors who take care of Hispanic patients, we invite all doctors that are not Hispanic to join us, and we do work with our African American comrades,
National Medical Association.
And the National Medical Association, and also the Asian doctors and the Native American doctors. In fact, we just formed a new nonprofit in the last couple of months called the Alliance of Multicultural Physicians. Oh. And so I think we have to learn from our communities that have a lot of minority people, or such as Puerto Rico. But do you want to comment on what you thought was part of the model and lessons learned in Puerto Rico with strategies that they did?
Yeah. I think that, they were probably some of the most challenged areas hit, where, population of a little over 3 million, half the people left, came back to the States because there was no work. As I said earlier, the economy was based on the pharmaceutical industry and tourism. Both of those were decimated. The power grid went out, was not handled well by the government, was corrupted, and people struggled over there. Yet, what was really terrific, I'll give you some examples. Lin-Manuel, who's many of you know from In the Heights and from
Hamilton.
As a Puerto Rican, took it upon himself to mobilize his people and get down there. Surgeon General Tony Novello, one of my predecessors, spent a lot of time there and is still there every week, making sure people get vaccinated, making sure food comes in. And then you had the famous chef who bought food, again, for a Spanish chef from Spain, who took it on his own to just fly down there and make sure everybody had a meal. So where the government struggled because of political division, the private sector stepped up and said, this is about humanitarianism. This is about doing the right thing. So I was very proud of all of them, for their willingness to step up and do that. I just spoke to Tony Novello about a week ago. She's still down there vaccinating people. She's retired.
Oh,
okay.
Good for her.
But those are the things, Lin-Manuel had a concert, raised a lot of money. The money then was given to the people to help to rebuild, to make sure there was electricity and clean water and food. So I think it's remarkable how Americans can step up and take on these responsibilities. Chef Andreas, he came, he's got this global food thing. Anytime there's a disaster, he gets on a plane with his people and he feeds the people. He's been in the Ukraine, he's been in Puerto Rico. So those are the people that deserve the credit, because where government stumbles and partisanship maybe prevails and prevents a timely response, that the public, good people just step up and took care of business. So I'm really, to me, that speaks of Americanism, not any ethnicity or gender. It's just like, you look and say, those people need help. Let's go do something. And so that's what I'm most proud of as an American. And we are, let me put it also, we are the emergency response for the world. When Indonesia crashed, it was our teams that went over there and helped them during the disaster, after the disaster, rebuilding. We had engineers, sanitary engineers, public health people. We had a Navy ship out there with public health service, Navy, Coast Guard, Army, all out there helping to rebuild. And we do this all over the world. And rarely do we get the credit that we deserve as a nation. And even though we're struggling, we always have the heart to reach out to others. It's something we should be very proud of.
Yeah. So I have one question that is a little off of the subject COVID-19, but I'm going to preface this. CDC has started to provide funding for health equity, workforce, and I have to say that this administration, I think the wake-up call of COVID-19 and the essential being the target of the virus for many, many reasons. I mean, having to face the virus, having to, living in multi-generational housing, being in communities, all of that. But COVID-19 and also the whole concept of Black Lives Matter and the George Floyd case that we lived through as COVID-19 was starting, that I think really brought up to the society in general the importance of changing the situation by being more positive about all the disparities we live through and trying to be actionable, to have actionable priorities. So CDC and others in the federal government are all focused on building a workforce around health equity, not as well as diversity, which means having more Latinos and African American, Native American.
Yes.
That would be the doctors and nurses of the future to handle the next pandemic. But one of the major efforts, though, that has happened from the Supreme Court, being as conservative as it is, and actually there's two things that are, another thing's about to happen, but the focus of the question was about abortion. and the overturning of Roe versus Wade, and the impact that it's going to have. And it is a public health issue. I'm going to answer that question right now, but it's more than a public health issue. It's going to be a workforce issue because so many of the doctors and nurses who take care of pregnant women and have to deal with medical emergencies are going to have to make decisions on the legal issues in their state. And the states are now, deciding whether they're going to go on one side or another of these maternal health services or women's reproductive services. What do you think about the importance of our doctors in terms of having a more diverse medical force in this country and taking care of our communities? And it's going to become very frustrating, and there's going to be a lot of conflict, I would imagine, and a lot more mental health issues than what we saw with COVID-19 among our own workforce. But what do you think can we do about this in terms of training and educating?
Again, your questions are kind of fodder for a PhD thesis. It's tough, but I'm happy to answer. First and foremost, as it relates to equity, it's not only health equity, it's social equity. I mean, people have to feel like they belong, that they are trusted, and that they can trust the people around them. We would joke, as a nation, we are all created equal, but it appears that some of us are more equal than others. And so the challenge, of course, is how do we achieve that equality? And you pointed it out. When you see a Black man with police kneeling on his neck, and all these other atrocities that have occurred in the last year, everybody has to pause and say, what's going on here? Now, listen, these were individuals who did bad things. I've been a police officer. Most of the cops I work with are good people. They will risk their lives to save somebody every day. But you have bad apples every place. We got docs that are bad. We got nurses. It's not a perfect society. So we have to figure out how we can be more inclusive, not only in health, but having people feel they're part of a bigger system where they have opportunity to advance based on their character, based on their values. The issue of abortion is a real tough one. I can understand those that are entrenched religiously and they feel, it's protecting the baby and all of that stuff. I got it. But for me, what is paramount is the woman's health. That is really what's paramount. Now, as you remember, Elena, this was something I used to get challenged on all the time when I was in office. And the reporters would say to me, well, Surgeon General Carmona, are you pro-life or are you pro-choice? And I would say, I'm both. And they, oh, you can't be both. I said, why? Because you have an artificial dichotomy that you've created? I said, I believe in the right of a woman to make the decision that's based on her needs at that time. I don't believe that we should be looking at abortion as a method of birth control, okay, because that doesn't make any sense. It's too risky. So I said, but you didn't ask me the right question, reporter. If we really wanted to address this thing, you should be asking me, how do we rid ourselves of the need of abortion? I'm like, okay, well, how? And then I would say, well, I'm glad you asked me the question. Here's how. If we make sure that every woman in the United States has unrestricted access to reproductive health care, over time, abortions will go away. Because no woman wants an unwanted pregnancy. A lot of it is because lack of education, a lack of getting condoms, lack of birth control pills. I mean, you go through poor people and you look at the demographics and you see where it's occurring. Well, unwanted births occur in people who are wealthy, and it also occurs in people who are educated. But with the appropriate education, with the appropriate insurance that every woman has that access, you would see the need for abortions to go down significantly. Yet we continue to make it polarized and political, where we shout and yell at each other. So my goal when I was Surgeon General was to try and diffuse that, but ultimately realizing as a physician, I have to be sensitive to the needs of the mother. And we've seen these cases play out just recently. A woman who has a child that's going to be born anencephalic, no head, and yet she has to carry it to term. I mean, what you mentioned it, Elena. What are the mental health ramifications of that? When you know your baby's going to be born with no chance of viability, okay? So it is the intended consequences of preventing random abortions. Okay, I got you, I understand. but you have many unintended consequences that are hurting women and women's health. And this is a public health issue. So we have to back away from the partisanship now that each side is leveraging their own arguments and start focusing on how we do something that makes sense for women and making sure that every woman has unrestricted access to reproductive health care with the goal of eliminating abortions as a random act because you didn't take protection.
Thank you. And with that, Surgeon General Carmona, I really thank you very much and really appreciate your time and your wisdom. And we need to do this again.
Love to.
And with others, and just have dialogues from everyone's experience to share. So let me thank you again. And on behalf of NHMA, we welcome you to join us again. And I do want to get you to our national conference.
Well, Elena, thank you so much. And thank you all who are listening. Really appreciate it.
Yes. Wanted to just make a last comment here on the slides and thank everybody. Thank everyone and welcome people to join us at our events upcoming. We are having our chapter events around the country in September 9th week. We are at the Southern California chapter at the University of Southern California's Caruso Catholic Center from 6 o'clock until 9 o'clock. There will be dinner and entertainment, as well as about 5 or 6 doctors discussing their leadership. They're all from different hospitals and they're bringing their own medical students and residents. So we're hoping to build up our membership there in Southern California. We have an HIV chapter forum, September 14, and we have a COVID-19 virtual briefing session. The next one will be in October 26th. In terms of our NHMA conference that I mentioned, we're leaving Washington, D.C. to go to Chicago, April 27th to April 30th. We will be at the Hyatt Regency. We're looking for speakers. We have a speaker abstract deadline of September 30th. We're also looking for sponsors and partners. And please call our office at 202-628-5895 so I can meet with you about sponsorships. In terms of our Vaccinate for All campaign, we have new websites, our hispanichealth.info and vaccinateforall.org. And again, we ask people to register for free to join over our 200 individuals and organization champions that we have with our Vaccinate for All campaign. This is supported by the CDC. That campaign also has our NHMA Leadership Fellowship that are training 20 doctors at a time. We've gone through 2 classes. We're going to start recruiting for the 3rd class. 20 doctors interested in public health leadership for the country. And as we mentioned, how important it is to get more of us to learn about public health and to join in on the all of the activities that Surgeon General Carmona mentioned that was needed to fight off pandemics. The other thing I want to mention is that to remember to complete our post-webinar survey that will be sent to you after this to win a $25 Amazon e-gift card. And I just want to mention our actual website is there at the bottom right, nhmamd.org, to see more information about all of these activities. And one last thing is the National Hispanic Health Foundation, which is our foundation, has a scholarship program, and we're actively also looking for supporters for our National Hispanic Health Professional Student Scholarship Program. Those galas will be in New York City and in Los Angeles. Los Angeles is the week before Thanksgiving. New York City is the week after Thanksgiving. And we hope that some of you would join us for that. So again, on behalf of the National Hispanic Medical Association, it's Dr. Elena Rios. I'm very happy that you were able to join us today. And we will be recording this and having it on our website in a week. Thank you very much. Thank you, Dr. Carmona. See ya.